Greetings to Dr. Ikban and Dr. De Guzman. We are Group 3 and we will be reporting exercise 6. Here are the group members. Presentation. Here we have a 60-year-old male patient, a construction worker that developed a peptic ulcer disease due to chronic intake of ibuprofen. He sought a consultation due to increasing severity of epigastric fate, not relieved by antacid containing aluminum hydroxide, magnesium hydroxide, and simethicone tablet. The patient denies history of ulcer complications in the past but maintained hydrochlorothiazide and lisinopril for hypertension. For the physical examination, the blood pressure is 150/90, cardiac rate is 85, respiratory rate of 20, and temperature of 36.5. For the laboratory results, the patient tested positive for H. pylori test. For the management, the patient was prescribed with clarithromycin, amoxicillin, and omeprazole for 14 days to treat H. pylori infection and was also given diclofenac for acute pain.
For the pathophysiology of our case,
So moving forward with pathophysiology of gastric ulceration, gastric ulceration could be caused because of three reasons. Firstly, H. pylori infection. So H. pylori infection would eventually release its toxins, leading to activation of an inflammatory response, which would activate interleukin 8 and interleukin 1b, which will lead to increase in production of H plus ions or hydrogen ions, leading to again mucosal injury and further gastric ulceration. Secondly, we have cyclooxygenase inhibitors. So, if there is inhibition of cyclooxygenase inhibitor, if there inhibition of cyclooxygenase 2, it would further inhibit leukocyte adhesion and further it would lead to increase in ROS, leading to again mucosal injuries, and further the end result would be gastric ulceration. Then thirdly, we have long-term use of NSAIDs. The example for NSAIDs could be ibuprofen. So this basically has three mechanisms to cause gastric ulceration. Firstly, inhibition of cyclooxygenase 1, which would further lead to decreased levels of prostaglandin, which would eventually lead to low blood flow and again mucosal injury and gastric ulceration. Second mechanism is topical irritation. Because of NSAIDs, there could be a possibility of topical irritation leading to epithelial damage and then directly mucosal injury and again gastric ulceration. Thirdly, we have inhibition of cyclooxygenase 2 leading to inhibition of leukocyte adhesion and increase in ROS, further leading to mucosal injury and gastric ulceration would be the end result.
Now let's proceed with the pharmacodynamics. For ibuprofen, it is classified as an NSAID, and its mechanism of action involves the inhibition of the enzyme cyclooxygenase. Adverse effects of ibuprofen may include nausea, vomiting, gas, bleeding, dizziness, and headache. It is contraindicated in individuals with heart disease, heart attack, stroke, or blood clot, stomach ulcers or bleeding, liver or kidney disease, and asthma. Ibuprofen is categorized as pregnancy category B, indicating no evidence of risk in humans during pregnancy. Regarding breastfeeding, adverse effects on the breastfed infant and effects on milk production have not been reported. Aluminum hydroxide is classified as an antacid. Its mechanism of action involves neutralizing hydrochloric acid in the stomach, resulting in increased gastric pH inhibition of pepsin activity. Adverse effects of aluminum hydroxide may include constipation, intestinal obstruction, fecal discoloration and impaction, nausea, vomiting, stomach cramps, hypomagnesemia, and hypophosphatemia. Contraindications include hypophosphatemia, acute porphyria, and prolonged use in renal failure. It is categorized as pregnancy category B, indicating no evidence of risk in humans during pregnancy. According to the World Health Organization, aluminum hydroxide is considered safe during pregnancy. Magnesium hydroxide is classified as both a laxative and an antacid. Its mechanism of action involves functioning as an osmotic agent, increasing the water content of stool. Adverse effects typically lead to evacuation within 4 to 6 hours, sooner in larger doses. It is contraindicated in individuals with inflammatory bowel disease, hypersensitivity to magnesium, low potassium levels, and renal failure. Magnesium hydroxide supplementation during pregnancy has not been formally assigned to pregnancy category. It might delay the onset of lactation. However, it can be taken during breastfeeding and no special precautions are required. Simethicone is classified as a miscellaneous GIT drug, specifically an anti-flatulence medication. Its mechanism of action involves being a non-systemic surfactant that decreases surface tensions of gas bubbles in the GI tract. Adverse effects of simethicone may include nausea and diarrhea, and is contraindicated in people with allergies. It falls under pregnancy category C, indicating potential risk, but benefits may warrant in its use in pregnant women. Simethicone cannot be transferred to breast milk and is considered safe to use during breastfeeding. Hydrochlorothiazide is classified as a thiazide diuretic. Its mechanism of action involves inhibiting sodium chloride transport in this convoluted tubule. Adverse effects of hydrochlorothiazide may include headaches, rash, hives, swelling of the mouth and lips, wheezing or trouble breathing, asthma attacks, and anaphylaxis. Contraindications include anuria, hypersensitivity to hydrochlorothiazide or other sulfonamide-derived drugs, severe renal and hepatic failure, Addison's disease, and hypercalcemia. It falls under FDA pregnancy category B, indicating no evidence of risk in humans during pregnancy. Doses of 50 milligrams daily or less are acceptable during lactation. However, intense diuresis with large doses may decrease breast milk production.
Next, we have lisinopril, which is classified as an ACE inhibitor. Its mechanism of action involves competitive inhibition of the angiotensin converting enzyme, preventing the conversion of the angiotensin 1 to angiotensin 2, which is a potent vasoconstrictor. For the adverse effects of lisinopril, which includes hyperkalemia, dry cough, angioedema, hypotension, dizziness, headache, renal insufficiency, and hyperkalemia. For the contraindication, include history of angioedema, renal failure with prior lisinopril use, and bilateral renal artery stenosis. Lisinopril is classified as pregnancy category D, indicating potential risk to the fetus. Manufacturers recommend against its use in breastfeeding women due to uncertainty about the amount secreted in breast milk and its effect on the breastfed infant. Next, we have clarithromycin, which is classified as a macrolide antibiotic. Its mechanism of action involves penetrating the bacterial cell wall and reversibly binding to domain 5 of the 23S ribosomal RNA within the 50S subunit of the bacterial ribosome. This binding blocks the translocation of amino acid transfer RNA and inhibits polypeptide synthesis. Its adverse effects include diarrhea, nausea, abdominal taste, dyspepsia, abdominal discomfort, transient hearing loss with high doses, and pseudomembranous colitis. Contraindication to clarithromycin use include hypersensitivity to clarithromycin or any macrolide antibiotics. Clarithromycin is classified as FDA pregnancy category C, indicating potential risk but benefits may warrant use in pregnant individuals. It passes into the breast milk in very small amount and is unlikely to cause side effects in the baby. Next is amoxicillin, which is classified as a penicillinase inhibitor with a wider spectrum. Its mechanism of action involves competitively inhibiting the penicillin binding protein 1 and other high molecular weight penicillin binding protein, which prevents bacteria from building and repairing their cell walls, leading to bactericidal action. Its adverse effects include allergic reactions such as urticaria, severe pruritus, fever, joint swelling, hemolytic anemia, nephritis, and anaphylaxis, and also gastrointestinal disturbances. Contraindication to amoxicillin use include serious hypersensitivity to amoxicillin or other drugs in the same class, such as penicillin hypersensitivity, and anaphylactic reaction to beta-lactam, such as cephalosporin or carbapenem hypersensitivity. Amoxicillin is classified as pregnancy category B, indicating no evidence of risk in humans, but caution is advised. There are insufficient studies in women to determine the risk of infants when using this medication during breastfeeding. Therefore, it's essential to weigh the potential benefits against the potential risk before taking this medication while breastfeeding. Next, we have omeprazole, which is classified as a proton pump inhibitor. Its mechanism of action involves binding covalently to cysteine residues via disulfide bridges on the alpha subunit of the HK ATPase pump, thereby inhibiting gastric acid secretion for up to 36 hours. Adverse effect of omeprazole includes headache, nausea, vomiting, diarrhea, hypersensitivity reactions, angioedema, and interstitial nephritis. Omeprazole is not considered teratogenic, and it is generally considered safe to use during breastfeeding.
Lastly, we have diclofenac, which is classified as a non-steroidal anti-inflammatory drug or NSAID. Its mechanism of action involves inhibiting the cyclooxygenase 1 and 2, the enzyme responsible for the production of prostaglandin G2. Adverse effects of diclofenac include hypersensitivity reaction, angioedema, and interstitial nephritis. Contraindication to diclofenac use include known hypersensitivity to diclofenac, allergy to aspirin or other NSAIDs, asthma, blood disorders, and hypertension. Diclofenac is not considered teratogenic, and it is generally considered safe to use during the breastfeeding.
Now we move forward to the pharmacokinetics of the drugs. So first we have ibuprofen. This is rapidly absorbed from the GI tract, partially into the skin. Food intake decreases absorption rate. The volume of distribution of this drug is approximately 0.12 liters per kilogram, and its plasma protein binding is approximately 90 to 99%. This drug is extensively metabolized to inactive compounds in the liver, mainly by glucuronidation. It is mainly excreted via urine, with 45 to 80% as metabolites, approximately 1% as unchanged drug, and 14% as conjugated. The biliary excretion of unchanged drug in active phase 2 metabolites represents 1% of the administered dose. The next drug would be aluminum hydroxide. It is slowly converted to aluminum chloride, which is absorbed from the gastrointestinal tract. Approximately 17 to 30% of this drug is absorbed. For its distribution, a single dose of 156 milliequivalents of antacid given 1 hour after a meal effectively neutralizes gastric acid for up to 2 hours. It does not undergo any metabolism as it is rapidly excreted in the urine. And this is mainly excreted via urine for approximately 17 to 30%. Next is magnesium hydroxide. It is poorly absorbed from the small intestine with a bioavailability of approximately 15 to 50%. It crosses the placenta and enters breast milk. This drug does not undergo any metabolism and it is mainly excreted via urine up to 30% as absorbed magnesium ions. And the unabsorbed drug is mainly excreted in the feces and saliva. Next is simethicone. This drug is not absorbed in the gastrointestinal tract and it has no distribution and metabolism due to poor absorption. It is excreted via feces as an unchanged drug. Next is hydrochlorothiazide. When taken with a meal, its bioavailability is 10% lower, Cmax is 20% lower, and Tmax increases from 1.6 to 2.9 hours. Its oral duration is 8 to 12 hours, and it has a bioavailability of approximately 65 to 75%. Its volume of distribution is 0.83 to 4.19 liters per kilogram with a plasma protein binding of approximately 40 to 68%. This drug is not metabolized and its renal clearance in patients with normal renal function is 285 milliliters per minute.
The next drug is lisinopril, a widely used antihypertensive drug. Once ingested, lisinopril is well absorbed through the GI tract, with about 25% of the drug making its way into the bloodstream. Interestingly, it doesn't bind to the plasma protein, allowing its distribution freely throughout the body tissues. Unlike many drugs, lisinopril remains unchanged as it travels through the body, eventually being excreted in the urine. The elimination half-life of lisinopril is around 12 hours, meaning it stays in the body long enough to maintain its blood pressure lowering effects throughout the day. The next drug we have is clarithromycin. It's an antibiotic known for its rapid absorption and moderate bioavailability of 50%. Once absorbed, clarithromycin spreads widely through the body tissues, concentrating especially in the liver and the lungs. About 70% of it binds to the plasma protein. The liver plays a crucial role in metabolizing clarithromycin, transforming it via cytochrome P450 system into several metabolites. One of these metabolites, 14-hydroxychlorothromycin, also possesses antibacterial properties, enhancing the drug's effectiveness. With an elimination half life of 3 to 4 hours after a single dose and extending to 5 to 7 hours with multiple doses, chlorothromycin is excreted through both urine and the feces. Moving on to the next drug, amoxicillin, another common antibiotic, boasts a high absorption rate with 70 to 90% reaching systemic circulation. This drug distributes extensively across various body tissues, although only about 20% binds to the plasma protein. Amoxicillin undergoes partial metabolism, leading to inactive metabolites. The majority of the drug is excreted unchanged in the urine, with around 60% of an oral dose being cleared from the body within 6 to 8 hours. Its elimination half-life is relatively short at just 1 to 1.5 hours. The next drug is omeprazole. It's a proton pump inhibitor. Omeprazole is rapidly absorbed, but its bioavailability is somewhat limited to 30 to 40% due to first pass metabolism in the liver. It binds extensively to the plasma protein, which is about 90%, 95%. The liver cytochrome P450 enzyme, particularly CYP2C19 and CYP3A4, metabolizes omeprazole extensively. Although its elimination half-life is short, which is between half an hour to 1 hour, the drug effects are long-lasting due to its irreversible binding to the proton pumps in the stomach. Omeprazole is excreted through both urine and feces. Moving on to the last drug, which is diclofenac. It's a non-steroidal anti-inflammatory drug, or NSAID, which is quickly absorbed through its bioavailability, and it's reduced to 50 to 60% because of the first pass metabolism. It binds almost completely to plasma proteins, predominantly albumin. The liver extensively metabolizes diclofenac via CYP2C9, producing several metabolites, some of which are active. Diclofenac has an elimination half-life of 1 to 2 hours and is excreted through both urine and bile.
Let's now discuss the indications and effects of the drugs.
Ibuprofen is a medication used to manage and treat inflammatory diseases, rheumatoid disorders, mild to moderate pain, fever, dysmenorrhea, and osteoarthritis. It is also available as an over-the-counter medication for pain, usually mild. Ibuprofen exerts its analgesic, antipyretic, and anti-inflammatory effects through the inhibition of cyclooxygenase pathways, particularly COX-1. This inhibition subsequently reduces the production of prostaglandins, which are key mediators of inflammation, fever, and pain. Aluminum hydroxide finds application in various indications, including temporary symptomatic relief of heartburn and gastroesophageal reflux disease, and topical relief of irritation associated with minor wounds and burns. Additionally, it serves as an adjuvant in some vaccines to enhance immune response. Aluminum hydroxide exerts its antacid effect by chelating protons in the stomach, leading to increased pH and reduced gastric acidity. This effectively relieves symptoms of indigestion but warrants caution for long-term use or administration to patients with renal dysfunction due to potential aluminum accumulation. Magnesium hydroxide is indicated for the short-term management of occasional constipation. It functions as an osmotic laxative within the gastrointestinal tract. Magnesium hydroxide exerts its laxative effect by drawing water into the lumen of the intestine. This increases stool water content, promoting bowel movement and easing constipation. In addition to its laxative properties, magnesium hydroxide can also act as a weak antacid. It neutralizes stomach acid to a lesser extent, offering some relief from heartburn and indigestion. Simethicone is a silicone-based medication indicated for the symptomatic relief of flatulence and bloating. It is effective in reducing the discomfort associated with excess gas in the gastrointestinal tract. This acts as a non-systemic surfactant in the GI tract. It reduces the surface tension of gas bubbles, allowing them to merge and pass more easily as flatulence or belching. It does not affect the actual production of gas. Hydrochlorothiazide is FDA approved for two main uses. First is for treating essential hypertension, either alone or combined with other medications, and second, for reducing peripheral edema caused by various conditions like heart failure and certain medications. This acts as a diuretic by increasing sodium and water excretion in the kidneys. This lowers blood pressure initially through volume reduction and potentially through vasodilation in the long term. Lisinopril is FDA approved for three main uses. First, for treating high blood pressure in adults and children over 6 years of age. Next, as an add-on therapy for heart failure, and lastly, for improving survival after a type of heart attack, for instance, STEMI, in stable patients. Lisinopril lowers blood pressure by relaxing blood vessels. It achieves this by inhibiting the conversion of angiotensin II that constricts blood vessels and reducing the production of aldosterone that promotes salt retention. Erythromycin holds FDA approval for treating a broad spectrum of bacterial infections. These indications encompass pneumonia, sinusitis, uncomplicated skin infections, and specific sexually transmitted infections. Notably, it is also included in the standard triple therapy regimen for eradicating Helicobacter pylori and is effective against atypical pneumonia caused by organisms like Mycoplasma pneumoniae and Chlamydia pneumoniae. Clarithromycin exerts its antibacterial effects by binding into the 50S ribosomal subunit of bacteria. This disrupts protein synthesis, which is a critical process for bacterial growth and survival. In some instances, high concentrations of clarithromycins can be bactericidal. Amoxicillin is an FDA-approved antibiotic for a wide range of bacterial infections, including ear, nose and throat infections, Helicobacter pylori eradication, lower respiratory tract infections, acute bacterial sinusitis, skin infections, and urinary tract infections. Amoxicillin exerts its bactericidal effect by inhibiting peptidoglycan cross-linking, which is a critical step in bacterial cell wall synthesis. This inhibition is achieved through the drug's binding to penicillin-binding proteins, ultimately triggering autolytic enzyme activity and bacterial cell lysis. For broader spectrum coverage against beta-lactamase-producing organisms, amoxicillin can be co-administered with beta-lactamase inhibitors. Omeprazole is FDA approved for various stomach and digestive conditions in adults and children. This includes treating peptic ulcers, both duodenal and gastric, healing erosive esophagitis, managing gastroesophageal reflux disease, and controlling hypersecretion in specific cases. Additionally, it is available over the counter for relieving uncomplicated heartburn. Omeprazole exerts anti-secretory effect by irreversibly inhibiting the hydrogen potassium ATPase pump within parietal cells of the stomach. This enzyme is the final step in gastric acid production. Omeprazole achieves a rapid onset of action within 1 hour with a peak inhibition occurring at 2 hours. Notably, the duration of its effect extends well beyond its plasma half-life due to this targeted and persistent blockade in acid production. Daily administration leads to a gradual increase in effect, reaching a plateau by the fourth day. Diclofenac is a prescription drug indicated for the treatment of acute and chronic pain associated with inflammatory conditions, particularly those affecting the musculoskeletal system. These conditions include osteoarthritis, rheumatoid arthritis, and ankylosing spondylitis. Diclofenac also has FDA-approved topical and ophthalmic formulations. Diclofenac also acts as a non-steroidal anti-inflammatory drug by inhibiting cyclooxygenase enzymes, specifically COX-1 and COX-2. This enzymatic inhibition hinders the synthesis of prostaglandins, particularly prostaglandin E2, prostacyclins, and thromboxanes, which are key contributors to the inflammatory and nociceptive response. Diclofenac demonstrates relatively balanced inhibition of COX-1 and COX-2, although it may exhibit some degree of selectivity towards COX-2. This mechanism effectively reduces inflammation and pain while also possessing antipyretic properties.
Drugs used in acid peptic disease are divided into two. First, we have the drugs that reduce the intragastric acidity and the drugs that promotes the mucosal defense. So under the drugs that reduce the intragastric acidity, we have first the antacids. These are combinations of various compounds with various salts of calcium, magnesium, and aluminum as an active ingredients. Antacid acts by neutralizing the acid in the stomachs and inhibiting the pepsin. Under this, we have sodium bicarbonate, calcium carbonate, and magnesium or aluminum hydroxide. Next, we have H2 receptor antagonist, which decrease gastric acid secretion by reversibly binding to histamine H2 receptors located on the gastric parietal cells, thereby inhibiting the binding and activity of endogenous ligands histamine. H2 blockers function as competitive antagonists. Under here, we have cimetidine, ranitidine, famotidine, and ezatidine. For the proton pump inhibitors, this blocks gastric acid secretions by irreversibly binding and inhibiting the hydrogen potassium ATPase pump that resides on the luminal surface of the parietal cell membrane. Drugs belonging to these groups includes omeprazole, esomeprazole, lansoprazole, dexlansoprazole, rabeprazole, and pantoprazole. So, moving on to the drugs that promotes the mucosal defense, first we have the prostaglandin analogs such as the misoprostol. This used in the treatment of duodenal and gastric ulcers. Misoprostol and other prostaglandin analogs protects the lining of the gastrointestinal tracts from harmful stomach acids and specially indicated for elderly in continuous doses of NSAIDs. Next is sucralfate. It dissociates in the acid environment of the stomach to its anionic form, which binds to the ulcer base. This creates a protective barrier to pepsin and bile and inhibits the diffusion of gastric acid. Sucralfate also stimulates the gastric secretion of bicarbonate and prostaglandins. Lastly, we have the bismuth compounds. It causes an increase in the mucous glycoprotein secretion and may also bind to the gastric mucus layer to act as a diffusion barrier to hydrochloric acid. CBS accelerates ulcers healing and causes an accumulation of epidermal growth factor around the ulcer.